Good evening, everyone, and welcome to the PENG second webinar of 2021, the PENG award winners. I'm just waiting for a few more people to log in before we get started this evening. So just make sure you've got a cup of tea beside you, your tea beside you, whatever it is to make you comfortable there listening at home. While we wait for everyone else to sign in, we'll just give people couple of moments. Good evening, everyone. Welcome again to the PENG 2021, the second webinar of this evening, of this year. I'm delighted to welcome you all here. I'm Linda, I'm the secretary of the PENG specialist group, and along with Carol Ann and Costas, we're going to be hosting this webinar for you this evening. I will hand over to Carol Ann just to give some background to the PENG award and what that is also here today. Thank you, Carol Ann.
Thank you, Linda. Good evening, everyone. And as Linda says, welcome to our second webinar of the year, where we are going to have some interesting presentations from the 5 PEN award winners of the PEN 2020 award. The PEN award runs annually, and our normal process is that we award a prize of £500 to 3 lucky PEN group members who have had their abstracts accepted to the PEN conference. And this is a supportive educational grant provided by Abbott, Nutricia and Fresenius, our 3 sponsors, who we would like to thank very much on behalf of PEN Group and the award winners. And normally the prize allows the individual to attend PEN and present their abstract in person. However, lots of things changed last year and PEN was online without an abstract section. Therefore, PEN decided that we would utilise the award that we had and we would divide it up into smaller prizes, and we would offer it to dietitians who wish to submit an abstract on their innovative work that had taken place during the COVID pandemic that we all had to deal with. We have got 5 presenters here who are going to share their original pieces of work of audit or service re-evaluation that they have in this area. So thanks very much to those who have come along. I hope you find the presentations interesting. And for those of you who are interested in applying for the PEN Group Award for 2021, we are hoping to be back at PEN live in Brighton on the 30th of November to the 1st of December this year. And the abstract call is open. All you have to do is, when you submit your abstract to PEN, the closing date for which is the 25th of June 2021, if you also send a copy of that abstract to the PEN address, which is attached to the PEN award submission, we will judge your awards, and we will have 3 prizes to allow people a fully funded place to attend PENG this year. But for the moment, we're going to present the 2020 awards, and I shall hand back over to Linda, who is going to introduce our speakers to you this evening. Thanks very much.
Thank you very much, Caroline. So as I said, we have, 6 speakers across 5 different presentations this evening. We will start with Emma, wave there, Emma, then Stella, then Steve and Rebecca, Francis, Naomi, and then Naomi. We will have each of them speak, and then we'll have questions at the end of each talk. So please use the questions box there to pose any questions to each of the speakers regarding their piece of work. And then we'll ask some questions at the end of each talk, but we'll also have some time at the end of each presentation or at the final end for some questions together to the whole panel. So over to Emma.
Hi everyone, thank you for joining today. My name is Emma Armstrong and I am a Senior Specialist Prescribing Support Dietitian from Guy's and St Thomas NHS Foundation Trust. Today I'm going to be presenting a new service that our community dietetic team implemented during the COVID-19 pandemic. The Guy's and St Thomas Community Dietetic Team provides support to community sites across 2 South East London boroughs, Southwark and Lambeth. This includes care homes, rehabilitation sites, community clinics, and to those who are housebound. The first wave of the COVID-19 pandemic caused a significant increase, 35 to 40%, in community dietetic referrals, many of which required urgent dietetic assessment. To support caseload demand and ensure patients receive timely dietetic review post-hospital discharge, the Community Dietetic Team implemented a new Virtual Dietetic Rapid Access Clinic, or RAC. The goal of the Virtual Rapid Access Clinic is to optimise patients' nutritional status by streamlining nutrition care between secondary and primary care settings. The RAC runs twice weekly with 2 dietitians undertaking 30-minute telephone reviews. Eligible patients receive a dietetic review within 2 weeks of hospital discharge. To be eligible, patients must be adults over 16 years of age, be community dwelling, free living or housebound, require oral nutrition support following an acute admission, including those requiring nutrition support secondary to the nutritional implications of COVID-19, and those identified as malnourished or at risk of malnutrition requiring dietetic review following hospital discharge. 6 weeks following implementation of the RAC, a random sample of 10 out of a total of 28 patients who had been reviewed in the RAC were audited. Electronic patient records were retrospectively reviewed by one dietitian to collect descriptive data of our service users, their nutritional status, and their path following review in the RAC. Results found that all 10 patients included in the audit met the referral criteria for the RAC. Patients' age ranged from 49 to 99 years, and there was a slight majority of female patients, 60%. Body mass index ranged from 14.1 to 29.9, with a median of 22. 80% of patients were at medium or high risk of malnutrition, and over half scored 2 or more on the Malnutrition Universal Screening Tool, indicating high risk of malnutrition. Patients were reviewed on average 12 days post-hospital discharge, and 80% were seen within the 14-day goal. Half of the patients had been prescribed ONS on hospital discharge, and 3 patients continued ONS following RAC dietitian review. Following RAC dietitian review, half of the patients were referred to the community dietetic team. 1 patient who had been followed up within 1 day post-hospital discharge was rebooked into the RAC clinic. 1 was referred to their GP dietitian, and 3 were discharged from dietetic care. The RAC was designed and implemented in June 2020 during the first wave of the COVID-19 pandemic. Implementing a new referral pathway to establish the service required collaborative work and close communication across all Geysers and St Thomas dietetic teams. Through weekly COVID-19 huddles, questions and concerns could be discussed and resolved. The community dietetic team collaborated with intensive care unit dietitians to ensure appropriate community support was available for patients post-ICU admission. Streamlining the referral process helped to reduce time required by acute dietitians when completing RAC referrals. This was supported by the administrative team and use of the electronic patient record system. The administrative team assists to ensure patients are available for their appointment, and RAC dietitians confirm patients have not been readmitted or experienced discharge delays. During acute assessment, dietitians gain patient consent for referral to the RAC and inform them of their appointment time. RAC dietitians identified between 7 to 14 days post-hospital discharge was optimal. Reviews set within 7 days had not provided sufficient time for patients to adapt to their home setting. Reviewing patients following 7 days at home ensured they could share experiences of eating, drinking, and achieving nutrition goals in their home environment, as well as highlight challenges faced and support required. For patients experiencing social issues, RAC dietitians facilitate prompt onward referrals to relevant local services, including social, voluntary, and local care networks. Within the appointment, RAC dietitians effectively prioritise the most pertinent issues and provide a detailed handover to the subsequent dietitian, highlighting key issues for follow-up. Implementation of the RAC has streamlined nutrition care for patients transitioning from the acute setting to the community. By providing dietetic reviews at the optimal timeframe post-hospital discharge, dietitians can facilitate the additional social or medical input required to support patients at home and more promptly amend or discontinue the use of ONS in cases when patients' nutrition status has been optimized. Following the initial pilot rollout, the RAC has continued for all patients who meet eligibility criteria. Ongoing evaluation incorporating patient feedback and clinical outcomes will be used to assess effectiveness and identify areas for development. Continuing to broaden and strengthen collaboration with primary care networks, including GPs, social services, and the voluntary sector, community multidisciplinary teams, and all relevant acute teams will continue to the ongoing success of the virtual rapid access clinic. Thank you.
Hello, Emma.
Hi.
Can you hear me okay? Thank you so much. What a brilliant presentation and summary of your new RAC clinic. I'm just looking at some questions
Thank you.
coming through here now. But I'm wondering, how has the RAC changed, obviously, since you've submitted that abstract, and in what way has it developed at all?
So I think it hasn't actually changed in the way it runs just yet. It is still being run as a virtual clinic. I think there was a lot of teething in the referral process initially, where patients might have been referred to the RAC but then actually been readmitted to hospital, or patients' hospital discharge had been delayed. So whilst the acute dietitians had thought a patient was going home, they put the referral in, the patient hasn't actually gone home, and we would sometimes have gaps in our clinic spots. So I think since the audit, we have done a lot of teething in terms of administrative processes, but the actual running of the clinic hasn't really changed as of yet. As things develop in terms of lifting of restrictions, potentially we will have an opportunity to use it with in-person reviews as well, not just virtual. So that will be exciting.
Absolutely. Have you found it difficult to connect with people over the phone? Has there been those difficulties to people, or them hearing you?
Yeah, I think that has been challenges that we've seen right across our dietetic service that haven't necessarily been unique to RAC, but with a lot of services going to phone reviews, dietitians have found it really hard without being able to visualize patients, or especially our community dietitians in the home environment, to get a real sense of, patients' ability to implement plans, the support they have, what's really going on. And definitely had issues with, communication, hearing, sometimes needing next of kin to be present for the phone review as well.
And have you had any feedback from patients about the service?
Yeah, so one of our RAC dietitians did send out our trust feedback forms to sort of get some patient input onto how they felt the service met their needs. We actually hadn't received any sort of written referrals, but we've had a lot of verbal feedback from patients, and they have found it sort of comforting and reassuring that they do get that clinician input, quite quickly after they've been discharged. And so we, sort of provide a point of call for them to really raise their concerns or issues with settling back into the home environment. So we've had some really positive verbal feedback, and we are adapting sort of our trust feedback forms that we're going to keep working on to try and get some more formal written patient feedback of the service.
That's great. Do you have any other questions, Caroline, there?
I can't hear.
I am off mute now. Emma, I just wondered, have you used or have you thought about using digital platforms to do your rapid access clinic? So in Scotland, we have a system called Near to Me, which is like this. It's a video system. And I know some places they're using apps on phones to do things. And I wondered if you had any plans to take it digitally, which means you can actually view the patients as well as speak to them.
Yeah, that's actually a really good question. To be honest, that hasn't been something we've discussed for our RAC clinic per se. I know some of our other clinical streams are using it. Our gastro outpatient service has that option, but it hasn't sort of popped up for the RAC. And I think, it's something we'll sort of look at in the future, whether or not we stick with the phone call, but for those patients that we might be worried about who could potentially come in person. But yeah, that's sort of a great idea and a great thought.
Thank you, and an interesting presentation. Thank you so much.
Thank you very, very much.
No worries. Thank you so much.
And so we'll move on to Stella.
Okay, hello. Just share my screen. Beginning. So hi, my name is Stella. I'm one of the prescribing support dietitians working at Aviva, and I'm going to walk you through the work that we did in care homes during the first wave of the pandemic. It's a service evaluation of the impact of rapid access service that was set up in care homes to support patients, staff, and GPs. So just to give you a little bit of a background, this is what the care homes prescribing support service looked like prior to COVID-19. The aim of the service was to improve malnutrition management, and the way we identified patients was through direct GP practice searches, auditing the GP practices to identify patients who are prescribed oral nutritional supplements, and offering a ONS review to care home patients who have not recently been seen by a dietitian in the last 3 to 6 months. And if the patients were at high risk of malnutrition, they were onboarded onto a 12-week care pathway with the dietitian. So the service used to be a hybrid of face-to-face and follow-up, face-to-face and remote care, where initial assessments were face-to-face and follow-ups were remote. And this was enabled by the use of Aviva technology. And the third part of the service, as it used to be, it was basically training and education to care home staff and to GPs. So as the pandemic started in March last year, it was agreed from April to September 2020 for that audit work previously done by the prescribing support dietitian service was non-essential, and therefore it was agreed with the commissioner for the care home service, for the care home prescribing support service, to continue supporting care homes with nutrition support and malnutrition management remotely. The service included 4 GP practices and their associated 12 care homes, and those were provided with a fully remote dietetic service. This was made possible as we already had processes in place for remote reviews. So we were able to quickly set up remote GP EMIS access as well on top of the Aviva systems that we had in place. We also continued to provide remote training for the care homes, whereas previously it was face-to-face. We now offered every 2 months remote training, and also they had access to our Aviva Learn content or Learn platform, which could be accessed at any time as kind of online training platform. So this is what the pathway looked like during the first wave. So we had we'd basically get a direct referral from the GP or the care home staff nurse, or we'd identify eligible patients, i.e. at risk of malnutrition, or patients who were prescribed an ONS supplement, and then they'd be onboarded onto a 12-week pathway. They'd be picked up for an assessment within a week of referral. So the dietitian assessment would consist of providing food first advice to care homes and supporting them along the way, but also the patients were follow up every 4 weeks during the duration of the 12-week pathway, either by the prescribing support dietitian or the dietetic assistant. And if the patient met the criteria, ONS would be initiated with clear goals, would be provided to the GP accordingly. And upon discharge, the GP would be provided with monitoring instructions, and if the patient remained at high risk of malnutrition, they'd be referred to the community dietitians. We also monitored, being a service evaluation study, we monitored outcome measures such as malnutrition risk, falls hospital admissions, infections, and ONS cost effectiveness at the beginning of the 12-week pathway and at the end. So these are the findings that we had from the study. So from 54 patients referred from 4 GP practices, 30 on ONS and 25 not on ONS, just referred because of their malnutrition. We found that we saw reduction in malnutrition prevalence, increase in average BMI, and also reduction in infections, falls, pressure sores, and hospital admissions. And we also monitored cost effectiveness, i.e. from ONS changes, and we found a £416 per patient cost saving from ONS changes. Other benefits that we recorded was patients at high risk of malnutrition were followed up as a part of their 12-week care pathway. Care home staff were supported regularly, and they had regular digestion point of contact, and GPs had dietitian as a regular point of contact as well. So just to show you the clinical outcomes in a little bit more detail, you can see that the must recorded at initial assessment and at discharge. So initial assessment in orange versus at discharge in blue. So we can see a shift from high to lower risk, especially for very high risk 2 and above. You can see a decline there. So we saw that patients at very high risk, so 2 and above, must have 2 and above, declined to 0 or 1 in 11 patients out of the 25 completers. And the number of medium to high risk combined declined by 28%. We also asked for feedback from the MDT, and we received positive feedback about the value of the service from the community dietitians, the GPs, and the care home staff, including comments on the quick response to queries and food first advice. So we did a further assessment or further cost benefit analysis on some of the clinical outcomes we recorded, in addition to the benefit from ONS changes. So on the left, you can see a table with estimated cost savings from ONS changes from the patients who were referred and were already on ONS, just by following local guidelines and changing where appropriate. Whereas on the right-hand side, you can see some of the cost benefits from improvement in clinical outcomes, i.e. decline in infections, falls, pressure sores, hospital admissions, and the decline from medium and high risk combined to low risk. And the cost estimation was assumed at a minimal cost, and it basically shows that combined cost saving from both ONS changes and from clinical outcomes equates to analysed cost saving of about £105,000, i.e. about £975 per person referred. It basically demonstrates the cost effectiveness of the service in addition to absolute savings from ONS changes, which is usually what commissioners would look to for a prescribing support dietitian to report on. So in conclusion, the audit demonstrated collaborative work during the pandemic months and how it was valued by the wider MDT, demonstrated remote dietetic support can be a valuable way to support care homes and care home staff and patients and GPs. And it also showed potential improvements in clinical outcomes for those at risk of malnutrition, including reduction in malnutrition risk, falls and infections, and how that could be a cost-effective service, especially when the benefit of both clinical outcomes were considered, as well as ONS changes. Thank you.
Thank you. Thank you very much, Stella. Are you there?
Yeah.
Oh,
hi.
thank you. Thank you so much. Brilliant presentation. Loving seeing all the community working presentations out here this evening. Can I ask you a little bit more, just I'm intrigued really about the Oviva technology? What is that? How does it work?
Yeah. So what what we used it for is mainly for patient records. So that's one thing that helps us to keep everything safe there. But we also had the Learn platform, which is the for healthcare professionals, for both GPs and care home staff, to remind themselves about the malnutrition guidelines and malnutrition management, food first. There is also video that we could use, but in the care homes it was mainly telephone, I think, due to capacity with the nurses. And whenever we had MDTs, we would use Teams as well.
Okay, so the Aviva is just a way of note sharing or for collaboration on it?
No, so there's obviously there's a video, but there's also app coaching on there as well, which again in face-to-face, or sorry, in patients who are outside care homes, it's more readily used, but in care homes wasn't utilized. But telephone and video was utilized.
Oh, I see, great. And so how did the care home respond to your more remote way of working?
So yeah, initially there were some teething issues in terms of kind of getting them to designate that time for telephone appointments and for reviews, as of course it was quite a stressful and difficult time for them at the time. But I think with time, as they understood the value of the service and appreciated the regular support from the dietitian, it actually became much easier to kind of designate the time and to book those appointments and to talk to them about the patients. And also it was kind of a two-way as well, because they appreciated the regular support. They would come in with phone calls as well. So yeah, so definitely difficult at the beginning, but with time they were much more receptive to it.
And you mentioned about some savings that were kind of generated from the ONS. How were them cost estimated again? Can you remember?
So the ONS savings are estimated by calculating the annual cost of the ONS a patient would be, the cost of ONS in the community a patient would be at their initial assessment versus their last assessment. So for example, if they're on a supplement, which is £2 per bottle or portion, if they were taking it twice a day, that would be 1,460 in a year. So if they change to something that's £1 per bottle or portion, then the cost would be half of that. So we would account the annualized cost saving that way. And the changes were based on the local guidelines where appropriate.
Okay. Do you have any questions, Caroline?
Yes, I have one question for you. Thank you so much, Stella. That was a great presentation. Are you going to change your practice ongoing, even although once we move out of the COVID restrictions that we have?
So yeah, it's an interesting question. So we have been, as I mentioned previously, before the pandemic, we've been doing a hybrid of face-to-face and remote. Yeah, I guess it will be a conversation that we'll have to have with the care homes and practices, and kind of see what their preference is. But I'd say it has been working really well up until now. So yeah, it's definitely something that we'd need to kind of discuss and see what's best going forwards.
Good. And we have a question come through on the chat function, which anyone who's listening tonight is more than welcome to place a question in here. But we have a question from Alison Culkin, and Alison has asked, what is the criteria for ONS, and was there any difference in the outcomes, and was there any difference in the outcomes between those at medium and high risk of malnutrition? So she's asking what your criteria for using the ONS was, and then with your high and low risk, was there any medium risk, was there any difference?
Okay, so the local prescribing criteria is basically if they're mastiff 2 and above, if they meet the ACBS criteria, and
what she's asking is between those
for 4 weeks, and then first line would be initiated if first line if food fast.
Okay, thank you.
Sorry, can you
Thank you
repeat the
so
last
much.
part?
Yeah, so the last part was there any difference in outcome between those at medium and high risk of malnutrition?
In terms of the clinical outcomes?
Yeah.
I'll have to go back look to the data for that. I'm not entirely sure, just off the top of my head.
Okay, but that's something maybe that you can consider for the future. So thank you, Stella. Thank you, and thank you to Alison for the question. And anyone else who has any questions ongoing, please just pop them in the chat function, and we will try to pick them up as we go along. Thank you.
Great, thank you.
Thank you, Stella. And now we have Stephen and Rebecca.
Hello and good evening, everyone. My name's Stephen Evans and I work here at the University Hospital of Wales in Cardiff. Let me start by thanking PENG for inviting me to present on our service evaluation, and thank you to PENG panelists for selecting us to win a PENG award. I'm going to present on our critical care service evaluation during the first wave of the COVID-19 pandemic. So obviously COVID-19 affected every aspect of the healthcare sector, but critical care in particular had a huge increase in admissions and a necessary expansion of footfall and services. Prior to COVID-19, we were 1.4 whole-time equivalent band 6 dietitians overseen by a clinical lead, and we were a 5-day service. At the onset of COVID-19, we very quickly switched to a 7-day service. This was to facilitate earlier assessment so we could see patients over the weekend, and also to allow us to do more frequent reviews. We were unsure about how to best manage these patients clinically. There wasn't a huge amount of evidence out there, so we felt it was important that we could see these patients as much as possible and have a high amount of oversight. We very quickly upskilled non-ITU dietitians to redeploy to the ITU, and we did this via one-to-one training and group presentations. We ended up with increasing to 5 band 6 dietitians with 1 band 7 dietitian overseen by the clinical lead. We did not implement a COVID-19 protocol or algorithm at this point, and I'll return back to that point later on, as I feel this was an important aspect of what we decided to do. So the aim then was to describe the nutritional management of COVID-19 patients with regards to energy and protein provision, the feed type that they were using, prokinetic use and bowel management, and then to evaluate how the changes that we implemented to the service impacted on these outcomes. Fortunately, just prior to the COVID-19 pandemic, we'd done pretty much the same service evaluation with our general ITU population. So we had these baseline data and results to compare to. So it was all ITU patients that were included that were diagnosed with COVID-19, and that ran from the 22nd of March to the 4th of June. This included 66 patients. So we have a look at some of the demographics then. The average age was 52 years and it skewed more towards a male population. This is in keeping with some of the ICNARC data that was published. The most common BMI was 30 to 34.9 at 32%. And if we look at all of the obese BMIs, anybody with a BMI over 30, that accounted for 53% of patients. If we look at predicted nutritional status on admission, we could see that 9% were considered to have some form of pre-existing malnutrition. This was deemed to be the case by a sort of subjective global assessment method. This is quite different from normal population. Liu et al. In 2017, in a systematic review, found that the prevalence of malnutrition in critical care patients was between 38 to 78%, but that was in quite a heterogeneous group, whereas this is all with COVID-19 patients. So if we look at our findings then, 94% of patients required enteral feeding, and 92% of these started feeding within 48 hours of admission. This is in keeping with ASPEN and ESPEN guidance on best practice that all patients should be enterally fed if indicated within 48 hours. The remaining 8% that didn't start feeding within 48 hours, the reasons for that were multifactorial and beyond the scope of this discussion that we're having now. So if we look at the average percentage feed delivery, that was 82.4% for both energy and protein. It's worth noting that this does not include the additional protein supplements that some patients are having. So this compares pretty favorably to the 85% that was found during the pre-COVID audit. We weren't entirely sure what to expect with regards to feed delivery. It's very well established that in critical care, underfeeding is quite prevalent. In some papers, the average feed delivery ranges between 40 and 60%. So we were happy with our 85% during the pre-COVID audit, but we felt that it was likely that this was going to decrease due to various amounts of challenges and barriers. For one, during the pre-COVID audit, there was no patients that were proned whilst being enterally fed, whereas in the COVID audit, 36% of patients were proned at some point during their admission. When you prone a patient, this eliminates the ability to use catch-up rate, and it does increase gastrointestinal intolerances and increases in gastric residual volumes. And also, you have to have generally a decreased rate of feeding, so it does have a significant impact on people's nutrition. Other barriers were redeployed nurses, as I said previously, redeployed dietitians who aren't exactly entirely familiar with the protocols. So we were very happy that we actually managed to get 82.4% feed delivery. And as I said before, we didn't adopt a COVID specific algorithm or protocol. We decided that we didn't want to distribute anything that was new because there was so much stress and uncertainty going on at the onset of the pandemic that we felt that we had these protocols already in place and we wanted to stick to those and to have as much dietetic input as possible. So you can see that this is reflected with 110 feed changes throughout the data collection period. We had a really big presence on the ward throughout the pandemic, and we were able to change people's feeds as needed to try to facilitate a better tolerance or to meet their requirements. So 36% of patients were prescribed a protein supplement at some point during their admission. These were the Renapro shots, 20 grams of protein, and these were often needed because patients were on filters or they were on a fluid restriction. You can see that the overall greatest proportion of patients were prescribed a fluid restricted feed, and that was 50%. That can in itself lead to some issues. Higher concentration feeds are associated with increased gastric residual volumes. This is perhaps reflected in our use of prokinetics. So prior to COVID, 29% of patients required the use of prokinetics due to high gastric residual volumes, and during COVID, that was 35%. So we did have an increase in prokinetic use to try to manage these increasing gastric residual volumes. So of all our patients, only 2 patients required TPM, which we were quite surprised about. We'd heard from other centres that PM was being used more frequently due to the aforementioned increase in gastric residual volumes. But we only had 2 patients that required PM. Not entirely sure why that is. It perhaps is because we have these validated bowel and prokinetic protocols that our team and our unit are very familiar with. So they were able to perhaps negate the use for TPM. So of those discharged from our ITU, 70% continued to receive full or supplementary enteral nutrition. We felt that was important because there was a lot of data coming out about rehabilitation needs of COVID-19 patients and how they could have quite a protracted journey to return back to baseline. So we were really very adamant that we wanted these patients not to have their NG just whipped out as soon as they were ready to step down to the ward. So with that in mind, we also advocated nasal bridles to be used to make sure that these tubes stayed in. So there was 28% had a nasal tube secured using a nasogastric bridle. So our conclusions is that COVID-19 pandemic presented new challenges and obstacles to every aspect of the healthcare sector, necessitating fast adaptations, novel methods of working, and reinforcing the importance of multidisciplinary teams to guide patient care in the absence of evidence-based guidelines and standards. This service evaluation demonstrates that forward planning and the expansion of the services in alignment with demand can assure that patient care need not be compromised. So we were very, as I said, we were very happy with this 82.4 versus 85% feed delivery, and we feel that the part of that was due to dietetic presence on the unit. I know I'm preaching to the choir here by sort of reinforcing the importance of the dietitian, but we felt that being able to go onto the unit as often as we were, being able to have these regular reviews and to make changes as needed really did allow us to maintain our high standards and our high expectations. That's all, and we'll take any questions now. Thank you very much.
That was brilliant. Thank you very much, Stephen. I know we've got Rebecca there with you as well. What great work. You've been very busy during this time. Some marvellous work there on ICU. We've got a few questions in. So again, some great results and well done. What were your cut-offs for GRVs on ICU?
We continued what we'd always done, because once again, as Steve mentioned in the presentation, we felt that trying to start changing the protocols that we use was going to be very difficult with, you know, lots of new staffing. So we kept at 300 mils, which is our cut-off, and our indication for prokinetics is usually post 3 high GRVs, which we count as over 300. But we also obviously consider the bigger picture. So if patients are vomiting or also have other abdominal symptoms, for example, high intra-abdominal pressures or abdominal distension or bowels not opening, etc., we would use it potentially earlier prokinetics if needed. And especially in our Crohn's patients, we found that we were sometimes a bit more flexible due to this risk of aspiration when you're placed in the prone position. But yes, we kept the same protocol, but we felt also initiate things if we felt that actually it was indicated.
Yeah, well, you clearly demonstrated that you kept up a similar rate of achieving energy and protein requirements, didn't you? So that was really, really good. And can I talk about energy and protein requirements? Did that change at all? Any of your targets for energy and protein in the COVID patients at all?
I would say we continued with the same way that we calculate our requirements. Obviously, like Steve mentioned, there's was a lack of evidence out there in terms of what we should be doing with COVID patients. There wasn't, for example, a COVID-specific requirement to be used. I would say because of the fact it is obviously has a massive respiratory impact, we were probably stricter than we might be with some of our other patients in terms of things like non-nutritional calories from propofol and citrate and all those kind of things. Due to the fact that could obviously exacerbate things if we're kind of overfeeding. But I would say our general underlying kind of way we manage the patients in terms of requirements stay the same. The only thing that probably massively changed was kind of the types of feeds we're using, especially for those patients who were in the prone position, or at one point we had a lot of issues with filters. So we were having to be a bit more strict in terms of our fluid balance targets, and therefore we found we were using lower volume feeds with more protein supplements in order to meet their protein requirements.
Great, thank you.
Thanks for an amazing presentation. That was so good, and hopefully that will inspire all the people in the audience who have had to make all the similar changes to yourself, as just how you can pull all that together into an excellent piece of work that informs practice and helps us to move forward. One question I have for you is, you said you changed the type of feed that you used. So do you have a standard feed in your protocol for starting an ITU normally? And if so, what feed did you change to? And did you have any problem getting a hold of stocks of feed as your numbers increased?
Yeah, that's a really good question. So we do have a standard feed that we start, but that is very much adapted, you know, by the dietitian if they feel necessary. So we don't necessarily keep all our patients on that protocol feed. But what we found is our protocol feed is a 1 cal per mil feed, but high protein. And we found that for, you know, patients who are in the prone position, and like I said, for patients who they were struggling with getting filters for, and therefore keeping them off the filter for longer than they normally would, we're using our lower calorie feeds, so more like a 1.3 or 1.5 cal per mil. trying to still get high protein. Some of them we did have to use a 2 cal per mil, which I know has been suggested potentially could exacerbate GI issues, but we didn't actually find that with the patients we used it for. But yeah, so that's the main ones we swapped to. But like you mentioned, we did have, I would say, yeah, large issues with feed delivery, which didn't actually have an impact on the patients because we managed to solve it quite quickly. But we did, because obviously our suppliers are very used to us ordering a set number of feeds of our normal feeds. As soon as we started ordering our 1.3 cal per mil high protein feeds in large doses, that was a real problem. And we did find that at times we did have to change, go back onto the unit and make last minute changes or send out notifications about what an alternative could be if they couldn't get it. But most of the time, as soon as we kind of flagged that to our pharmacy team, they were able to get kind of urgent supply in to be able to meet it. So they worked really well in terms of understanding how important it was to make sure we actually had the right feed, and the fact that just because it's feed, at first I think they felt, well, it's just a bottle of feed, can't you just use this one, without understanding the reason why you'd chosen it. So I think as soon as that was understood, they tried their very best to kind of make sure they had the feed available for us, and they did manage to pull it from lots of areas. I don't know how they did it, but they did, which was good.
Yeah, it was a UK-wide problem that everybody started ordering high protein feeds and looking for protein supplements and things to put into the feed. So there has been some work done with the BDA, and PENG Group have been involved with the BSNA to work with the companies for a resilience programme, which hopefully got us through the second wave, and there is a bit of planning going on behind a third wave if, goodness forbid, that happens, that the supplies are there so that we've got a stock in place. I think with a lot of these high protein feeds and specialist feeds, companies don't run a large stock because they don't normally use them, and we just had this massive demand came on. But it has been recognised and has been looked at a national level, and the BDA have been quite active in pursuing that. So that's helpful to know, and it's helpful for everyone to know moving forward that there is some resilience planning going on there. We have a couple more questions have come in. One from Georgia Hardy has asked us, do you know what, if any, oral diet patients were receiving at the time they stepped down?
So as far as, I'm just trying to think back to the data, we obviously know which patients were on full feed versus supplementary feeding. We didn't look into kind of the more details of exactly how much diet they were having and those kind of things in the audit. It was kind of, we're trying to keep it quite focused so we kind of have some clear data from it. But obviously any of the patients who are on overnight feeding rather than full feeding, for example, that will all be in our records, but in terms of actually the data, we don't have how much they're having.
Okay, thank you very much, and thank again to both of you. That was really interesting.
Thank you. Thank you very much.
Thank you. And now we have Francis.
Hi, my name's Francis. I am one of the dietitians working in Southmead Hospital in Bristol. Thank you very much for inviting me to come and present my abstract. So myself and my colleagues Ellie and Rowan, we carried out a quality improvement project to assess the effect of COVID-19 on nutritional intake post-ICU. So the background to this then is that we know from literature that an ICU stay can have adverse effects on nutritional status, with many patients experiencing significant weight loss post-ICU. Our own departmental audits have found that our ICU patients are relatively well fed when compared against data from the International Nutrition Survey, with most of our patients meeting at least 70% of their protein requirements during an ICU stay. However, we know less about what happens after ICU admission, and we know really nothing about how COVID-19 affects nutritional intake. Therefore, the aim of this project was to assess how an ICU admission with COVID-19 affected nutritional intake. To do this, we retrospectively reviewed all the patients who were admitted to ICU between March and May of 2020 with COVID-19. We excluded any patient who did not survive to ICU discharge. And we looked at the route of nutrition support. The nutritional requirements and nutritional deficits were recorded at ICU step down, ward discharge, and then follow up at home, which was usually between 4 and 12 weeks post hospital discharge, and just depended on when we had capacity to call them. We calculated nutritional requirements whilst an inpatient in line with our departmental guidelines. So for us, that meant for inpatients, if they were ventilated on ICU, we used the Penn state equation. And when they were no longer ventilated, both on ICU and in the ward environment, we used the Penn state non-ventilated equation. Our protein requirements were calculated with a range of 1.25 to 2 grams of protein per kilo of body weight. And then when we followed patients up at home, we used slightly higher energy and protein requirements. So we used 30 calories per kilo of body weight and 2 grams per kilo for protein. We used this higher range because, again, it was assumed that these patients would have higher nutritional needs for rehab. For any individual who had a BMI of more than 30, we calculated 75% of their energy requirements, and we calculated protein requirements using an ideal body weight of BMI of 25. We calculated nutritional deficits by calculating estimated intakes from food charts and dietary recall for both our inpatients and for those patients we followed up at home. We required no ethical approval because standard dietetic care was provided. And in total, we included 23 patients, and we were able to follow up 14 patients at home. So our results. So the results, the first thing we looked at was the route of nutrition support. So as you might expect, post-ICU, the rate of enteral nutrition remained quite high. So we had 50% of patients requiring sole enteral nutrition at ICU step down, with a further 13% requiring enteral nutrition to supplement their oral intake. 25% of patients required nutritional supplements to supplement their oral intake, and only 13% of patients required no nutrition support at ICU step down. At hospital discharge, again, as you probably would expect, the proportion of patients requiring enteral nutrition dropped, with only 5% requiring sole enteral nutrition at hospital discharge. The majority of patients, so 63%, required nutritional supplements on top of their oral intake, and 32% of patients required no nutrition support at hospital discharge. When we followed these patients up at home, again, this was 4 to 12 weeks later, we find that the majority of patients, so 71%, were receiving no additional nutritional support, and only 21% had ongoing access to nutritional supplements. One patient, which worked out at 7%, still required sole enteral nutrition in the community. The next thing we looked at was nutritional deficits. So with nutritional deficits, we find that at ICU step down, deficits were relatively low-ish, with 25% of patients experiencing more than a 30% deficit in their energy and protein intake. In the ward environment, sadly, nutritional deficits increased, and we find that more than half of patients on the ward were experiencing more than a 30% energy and protein deficit, and almost a fifth of these patients were experiencing more than a 50% deficit in their energy and protein intake at hospital discharge. Then when we followed these patients up at home, we find, sadly, again, that nutritional deficits increased further, particularly for protein. although it is important to note at this point that the sample size was a lot smaller. But we find that 58% of patients reported a 30% deficit in their energy intake, and 83% of patients were experiencing more than a 50% deficit in their protein intake. So what do those results suggest? So we find that, let me find my slide. So we find that, as you might expect, at ICU step down, the majority of patients required enteral nutrition or nutritional supplements, which could suggest an increased risk of malnutrition post-ICU. It's also likely that the high rates of enteral nutrition at ICU step down contribute to the lower energy and protein deficits reported. At hospital discharge, we found that energy and protein deficits increased, and the majority of patients were requiring nutritional supplements. The increased deficit seen at this point in the hospital journey could reflect the quicker than usual discharge planning that occurred during the first wave of the pandemic, which resulted in many patients having their NG tubes removed rapidly after ICU step down, followed by an even more rapid discharge into community. So given the quicker than usual discharges that occurred for some patients, it's quite possible that not all the patients will have received adequate dietetic counselling, particularly about high energy and high protein diets. And given the high level of nutritional supplements and nutritional deficits reported at hospital discharge, we think it's fair to suggest that patients were discharged into community at high risk of malnutrition following an ICU stay with COVID-19. When we followed the patients up at home, again, we find that very few were carrying on with their nutritional supplements, and we think this likely contributed to the large nutritional deficits we saw at home. Again, the high levels of energy and protein deficits could suggest an ongoing risk of malnutrition in the community. A possible reason for the low levels of nutritional supplements in community could be a failure of the dietitians in the hospital to request prescriptions from GPs, and it's also much more likely to have occurred for those patients who were rapidly discharged. It also likely reflects the limited dietetic resources available in the community in Bristol. And as a possible consequence of the increased deficits reported and the low nutritional supplements prescribed in community, it's possible that many of these patients will not meet their nutritional needs for rehab, and may struggle to restore the lean body mass they lost during their critical illness. However, really commenting on that is beyond the scope of this project. But to conclude, we find that energy and protein deficits increased following an ICU step down and continue to increase following hospital discharge. This is possibly due to reduced availability of nutritional supplements in the community. And lastly, just as a final reflection on this project, it was really challenging to undertake this project during a pandemic. And as a result, some of the data we collected is flawed. However, it was still a very rewarding experience, and it was really helpful to get an insight into the patient journey, particularly being able to follow these patients up in community. This project has definitely highlighted there's many areas where we can improve our service, particularly around communication to GPs and to patients post-hospital discharge. And we hope to redo this audit and take some of the learning forward in a similar audit where we look at long stay ICU patients who don't have COVID, and to see how their hospital journey compares. So thank you very much, and if you've got any questions, I welcome them now.
Hi, I think we're there now. Sorry, first bit of technical issues. But Oh, thank you very much, Francis. That was really good. So interesting, I think, as you said, to for the first time maybe follow that patient journey from ICU to home and see really what the impact is. And as you said, opens up our eyes to realise, COVID has opened up so many things that we were maybe missing before of that patient ICU journey. But absolutely, I mean, it is quite perhaps shocking in many ways, or that the number of patients, the percentage that weren't meeting their energy requirements when you followed them up. Do you think that, because I noticed that your protein requirements and energy requirements, they were set quite high.
Yeah, so I think whenever we kind of, I suppose, laid out kind of the layout of the project, and we kind of said, oh, we'll use these as the requirements. We just, for standard kind of inpatient ICU ward, we just use what we would normally do for standard care. But like you said, we wouldn't normally ever follow our patients up after an ICU stay unless they kind of met community dietetic services. We refer them in, but we personally would never kind of follow them up. So we didn't really know what requirements to use, and we couldn't really find an awful lot in literature looking particularly at rehab. So it was quite hard to find any references. And that was one of the only references we could find that has the quite high energy and protein recommendation for rehab. And the reference came from kind of an ICU, a couple of ICU, I think, doctors who looked at recommendations for ICU on the ward and at home. So that's kind of, we went with that one. And I think because we were just a bit panicked and frazzled collecting this data during the pandemic, we didn't really think about it until we got to the point where we were following them up. And then we realized that the requirements we'd set, especially for protein, were actually probably quite high. We were kind of almost setting a bar that was probably quite unrealistic for our patients to meet, meeting even higher protein needs in community than we would give them in the hospital. So yeah, it was definitely an interesting to kind of get that patient follow through at home and to see what happens. But probably in retrospect, we might use a slightly more conservative, particularly protein requirement if we were to do it.
And what were the barriers that people were sharing with you that, to their oral intake at home?
It was actually really interesting. So we didn't we find that most people were reporting they didn't have supplements. They went home with whatever the ward had given them as discharge. So that's normally about 7 days worth. And then most of them didn't get an ongoing prescription. And most people didn't want to go to their GP, understandably so. So weren't kind of then having those conversations about that not being carried on. A lot of patients were reporting things like taste changes, and they were then just reporting like the classic poor appetite. A lot of people were finding that they were still feeling quite unwell, quite weak, so they were relying on ready meals. Taste changes, and actually quite a few people had been readmitted to hospital as well with like a different illness, which again probably reflects how unwell they were, and again highlights they weren't really eating and drinking very well in community for quite a number of reasons. But yeah, that was quite an interesting finding too.
And did you gather any functional measures?
Yeah, again, gather any what? Sorry.
Gather any functional measures of their mobility, their physical function?
We did. So I did record it. We did it as part of like a slightly bigger project, like a bigger audit. So we did try to get some functional data, but it was really subjective because obviously we were just calling them over the phone, and we just kind of asked them before they came into hospital what their daily living they were able to manage themselves, how much support they needed at home, and then how that compared to now. And we find that nobody had returned to their pre-existing level of function. So quite a few people, like we had quite a few younger people, and none of them had gone back to work. And some of the older people, they all needed some additional help. And again, we were quite varied. We called people up normally between 2 and 12 weeks, so it depended when we called them. But none of the people we contacted had yet returned to their pre-existing kind of level of activity and function. But again, we just were very subjective using validated measures. Yeah.
Definitely a good piece of work then to put forward, you know, for the case for that rehab in the community.
Definitely.
Francis, that's a fantastic piece of work. Well done. It's really great. One question I had for you was, when they stepped down from ITU, was it a dietitian who made the decision to stop the enteral feeding and take the NG tube out, or did it just happen somewhere in that corridor between ITU and the ward that they're going to?
Very much so. Like we've struggled with that maybe pre-COVID on certain wards, particularly maybe more like general med wards. Actually, the respiratory ward, they're quite, they would be kind of like kind of trigger happy to remove tubes when they come from ICU. But that was something we find just on the whole, particularly it got much better in the second wave, but in the first wave, we find that some people maybe within 4 or 5 days would be extubated, have their NG tube out, and then be discharged home. So it happens so quickly that the majority of the time, for quite, I think I said it was 50% of people still had an NG in when we saw them after the first review. So the rest of them had lost them, and that was before we even got to see them on the ward. And none of us were advocating an NG removal before ICU discharge. So yeah, very doctor led.
Well, your audit
Thank you very much.
gave that results, didn't it, to show that you need to include the dietitian more because of them not meeting the requirements.
Yeah, definitely. Yeah, that's something we put in as if after the results of this, we made like a pathway, and that helped with the second wave to kind of like when people come from ICU, don't take the tube out until they've been seen by the dietitian. And we got our ICU consultants to put that on the ICU discharge as well, which I think really helped as well.
Good. Thank you very much, Francis. So we're on to our last speaker of the evening, Naomi. So I'll pass over to Naomi now to introduce her talk.
Hello everyone, I'm Naomi and I'm a dietitian working at the Royal Surrey in Guildford. I'm pleased to be able to share with you the results of our questionnaire investigating the barriers to enteral nutrition in patients with COVID-19 amongst healthcare professionals. Thank you to PENG for this opportunity to share this work, and also to Mary Phillips for her support with the project. Just to mention, this questionnaire is part of a larger project started during the first wave of the pandemic, in which we are hoping to achieve a retrospective review of factors affecting nutritional recovery following COVID-19 infection. So why, as part of this questionnaire, did we want to look at the opinions of other healthcare professionals? Well, we know that patients with COVID-19 are at high risk of malnutrition due to poor respiratory function and often the necessary use of non-invasive ventilation. In usual circumstances, it's widely accepted that for those unable to meet their requirements orally, we would recommend enteral nutrition, and typically this would be via the nasogastric route. However, in practice, what we were finding was there was resistance and therefore delay to enteral feeding in this patient group. So we thought it would be helpful, alongside the larger project, to run a questionnaire that looked at the opinions of healthcare professionals regarding the use of NG feeding tubes in patients with COVID-19 in order to identify barriers to nutrition support in this cohort. So a paper questionnaire was designed and reviewed by members of the department who at that time had been involved in the management of patients with COVID-19. This was piloted on a few members of staff to ensure it was quick and easy to complete, and to ensure that it captured the relevant data required. This was then distributed by members of the department for use on their usual ward areas, aiming to capture a variety of specialty teams and staff groups. Circulation continued until 100 copies were received. As mentioned, this questionnaire element of our project is part of the larger project, which had been approved by clinical audit. The data was then collated and analysed using the chi-squared test in SPSS, as this data was categoric and the variables were deemed independent. With regards to the questions asked, for the purpose of time, the results will only cover those in bold, but this gives an idea as to the themes of the questions asked of staff. We captured their current role, years of experience, usual specialty, and whether or not they were redeployed as part of the COVID response. We asked how many calories and grams of protein they felt were in the hospital menu. We asked whether they felt patients with COVID-19 were at risk of malnutrition and to list their reasons why. As part of our response, we developed a guideline surrounding nutrition support, so we wanted to know if they were familiar with this and if they had any barriers to implementing it. We asked if they prescribed oral supplements as per the guideline and whether or not they felt patients complied with taking them. We asked whether patients with COVID-19 requiring non-invasive ventilation should receive enteral feeding, and also asked for what factors they would be mindful of when considering NG insertion, and also what concerns they might have when using enteral feeding in this patient group. Finally, they were asked to rank the importance of the following factors from 1 to 5, with 5 being essential: preventing malnutrition in patients with COVID-19, meeting energy requirements within the first week of admission, meeting protein requirements within the first week of admission, ensuring patients have adequate nutrition before discharge, and asking how important is adequate nutrition to their outcome and rehabilitation in COVID-19 patients. So taking a look at the responses, the distribution of answers we received, we had 35% from the nursing cohort, from healthcare assistants through to senior matrons, 26% doctors of variable grade, 26% allied health professionals, and 13% from pharmacy. Typically, most had between 1 to 5 years experience, and you can see here that their usual area of work for many was in oncology and surgery, which is not surprising given that the hospital is a tertiary centre for both of these areas. With regards to redeployment, only a small number from each group stated they were redeployed to a different area. On reflection, we feel this question may have been misunderstood. Many staff remained working in their usual area and role, however were in fact responsible for caring for patients with COVID-19, as most wards did fill up during the first wave. Reassuringly, 75% felt that all patients with COVID-19 were at risk of malnutrition, with 22% feeling they were only at risk depending on their comorbidities or interventions. The responses did significantly vary across discipline, as outlined here, comparing 100% of dietitians with 39% of pharmacy staff feeling that they were all at risk of malnutrition. When looking at the reasons for risk of malnutrition, these were taken from free text answers and split into the themes listed here. It's interesting to see the variety of reasons given, all of which I'm sure you've seen in practice. Most frequently reported was low appetite, the use of non-invasive ventilation, and high nutritional requirements. When looking at the guideline awareness, when we excluded the dietitians from this, only 19% of staff were aware of the Trust COVID-19 nutritional guideline. As I mentioned, this provided information on appropriate use of oral supplements, but also how and when to safely administer enteral nutrition. On reflection, so much about the overall management of patients with COVID-19 was unknown during the first wave. There were updates and management changes so frequently, perhaps it's not that much of a surprise that such a low number were aware of it. Of those that did know about the tip but felt unable to follow it, there are a few reasons, such as feeling inexperienced to challenge nutritional decisions, feeling there was an inappropriate ward environment to support enteral feeding, of course the patient's ability to decline nutritional intervention, or an inability to obtain enteral access. Also mentioned was not having agreement from the managing clinician. When looking at the use of NG feeding during non-invasive ventilation, 35% stated that they would definitely use it, and 62% stating only sometimes, with 3% of staff saying that they wouldn't use it. It was nursing staff and dietitians that were most likely to state that they would use it. With regards to the concerns over tube insertion, 22% reported concerns about aspiration, 23% had concerns about poor mask seal, and 21% had concerns about desaturation during NG insertion. When comparing the groups, it was dietitians that were most concerned about desaturation, doctors most concerned about aspiration, and concerns over mask seal was consistent across disciplines. Apologies, we've lost the audio on this last slide, so I'll just talk through this with you now. I think the concerns raised are consistent with what's in the literature, so perhaps what we were expecting to see. It's known, of course, that the insertion of NG feeding tubes requires the removal of the non-invasive ventilation masks, and therefore those with severe disease may desaturate very quickly. And equally, once the tube is in place, the masks do need to be carefully fitted to prevent air leakage. Because of these known concerns, the guidance from BAPEN as part of the COVID response provided practical guidance to minimise the risks in this patient group. This included the use of silicone dressings and fine bore NG tubes to reduce air leakage, and also the consideration of using gastric decompression devices, the use of prokinetics, and measuring gastric residual volumes to reduce the risk of aspiration. I think from this questionnaire of our staff, it's shown that they were aware that patients with COVID-19 are at risk of malnutrition, but it's perhaps on a more practical level that more training and support was needed to help overcome some of these barriers. Ultimately, it is the role of the dietitian within the MDT to be the source of expert knowledge surrounding the nutritional management of these patients. And I think it would just be really interesting to reflect back on some of the lessons that we've learned this year as to how some of our management might have changed, particularly with supporting the MDT. Thank you for your time. I'm happy to take any questions.
That's great, Naomi. Thank you very much. Sorry, you did well keeping us all, and I chose there the last presentation, so thank you. I was just wondering if you were to, repeat that questionnaire now, what the responses might be, in particular those that feel that those are at risk of malnutrition with COVID. Is there any thoughts of repeating that at all?
Yeah, I think it would be really interesting to see the results from the first wave compared to the second wave. I think we've all learned a lot along the way. I think we were quite fortunate in that we were able to get a Band 6 dietitian that was specialising in COVID, so designated to go on the COVID wards, that was again newly built, kind of between first wave and second wave. So I suppose in the second wave we've then got a designated ward with a designated dietitian. So I think having that presence and kind of rapport from the dietitian early on would probably find that we would have less resistance to enteral feeding in this patient group, kind of earlier rather than later.
Absolutely. You mentioned that this was just a small part, of a questionnaire of a larger audit.
Yeah.
What else were you exploring, or what was that looking at?
Yeah, we're essentially trying to do this retrospective review of the factors affecting nutritional recovery. Essentially, we're just trying to look at the nutritional impact that COVID had on the inpatients we had here. We're looking at quantifying the impact that COVID had on their oral intake, and quantifying which patients had ONS or enteral nutrition or parenteral nutrition, looking at which patients were referred to the dietitian, and seeing whether or not they were would have been flagged up on must, because we know that that's maybe not something that patients may have, they're not our typical patients that would be at risk usually of malnutrition, but actually once they're in this disease state that they may need nutrition support. So it's essentially that really. It's quite a large project. We're going through all of the notes from the first wave, whether or not they were referred to us or not. So it's really interesting to see the gaps between the patients that weren't referred but might have benefited. But also looking and separating them into the disease severity as well, obviously, because the ceiling of care may have impacted on what interventions they received.
Got a lot of work there. We'll be interested, maybe another, PENG Award 21, you could definitely get more in there.
Absolutely. Naomi, you said that you were fortunate to get a Band 6 dietitian during the second wave to go into the COVID wards, but during the first wave, when you did your audit, were the dietitians actually going on to the wards and onto intensive care? And do you think there was any difference between intensive care wards and the step down to the other wards in their perceptions?
So I think in the first instance, we were expecting, very big surges of referrals to dietitians with all of these patients requiring CPAP or BiPAP. And I think initially that wasn't happening, and we were thinking, why is that not happening? And I think we then kind of made the decision to go onto these wards and kind of almost screen some patients ourselves if they've been in for kind of more, getting on to nearly a week. Has anyone seen them? So we developed some kind of pro formas as well that dietitians would take onto the ward, just to do a very kind of quick kind of look through notes, look through food charts, look at the management, and kind of just be able to kind of have that quite clearly in the notes to say, look, a dietitian's been involved, yes, they're okay, or actually we would recommend enteral nutrition. So I think rather than waiting on lots of referrals, we tried to kind of take that up on ourselves just to try and screen people, because we were finding a bit of a difference in patients that had been on the ward for quite a while, perhaps receiving CPAP, but not getting kind of enteral nutrition, for example, and they were kind of presenting to ICU in a poorer state than some of the ones that that may have just gone straight to ICU.
Okay, thank you very much.
Lovely. Thank you very much to all our speakers this evening. If you want to come back on the screen just to say hello, and thank you for all your talks this evening. It's been great hearing all your innovative practices, and also remind everyone to consider then applications for the award that's now live. As Caroline mentioned earlier, you can find it through the BPEN website. Also, just a final reminder also that our next webinar is coming up, and it's save the date for Tuesday the 8th of June, where a hot topic, as always, estimating requirements 2 years on. We have some fantastic speakers, so we look forward to welcoming you to the webinar on the 8th of June. So please look out for the registration for that coming soon after this evening. And thank you all again for joining tonight, and for all our speakers. Thank you.
Good night, thank you.
Thank you.